there's a lot of interest, and I think rightfully so, in hereditary kidney cancer, right? And it's more recently, I think, some more publications we'll talk about in a little bit. But let's kind of start broadly, just to understand and get kind of level set with our audience here. What is the percentage of kidney cancer that's considered hereditary, and why is it really important, kind of in urological oncology?
Yeah, so moderate to large sample studies like the TCGA have shown that about as much as 5 to 8% of kidney cancers are associated with some sort of germline alteration. And this number is a little lower with clear cell RCC, but it's on the higher end with other subtypes like papillary and chromophobe. And it is an important topic in urologic oncology as it directly affects patient care and their outcomes. So various hereditary cancer predisposition syndromes lead to the development of tumors, which need to be managed differently. So certain syndromes, like SDHB and HLRCC, necessitate operating at much smaller tumor sizes and with wide margins. Whereas other syndromes predispose patients to many tumors, say 30 to 50 over their lifetime. We need to modify these approaches to extreme tight nucleations. Otherwise, there'd be very little kidney left after any of these surgeries.
Yeah. Well, I want to ask you a kind of a follow-up question on that, right? So I think you talked to us briefly about what hereditary versus sporadic, right? Or you kind of mentioned hereditary. So germline versus kind of sporadic mutation. So give us a little bit of a background on that. So if it's germline, obviously it's in their germline, it's in their DNA, right? Something that they can actually they can inherit from family members. Versus sporadic, it's not necessarily hereditary, right? So give us that understanding between the two for people who are not very aware of that.
Yeah, that's absolutely correct. So essentially, a germline alteration is something that's inherited from your parents. And when patients will inherit this from family members, and what they'll notice is a lot of times these are associated with a family history of having a number of kidney tumors and et cetera. There are a number of different genes that can predispose us to having some of these tumors. To this count, there's 19 that have been identified already. And we know that this sensitizes patients to potentially having tumors down the line. Whereas sporadic is something that occurs sporadically or relatively randomly. There are a number of different risk factors that can cause this for renal cell carcinoma and other types of tumors as well. But they're much less likely to find like family interactions and outer family history. And when we see alterations in those tumors, we generally talk to them as somatic or changes within the tumor itself, but not with other cells within the body. And so these patients are more likely to develop one tumor over the course of their lifetime, usually more around anywhere between 50 to 70 years old, and are unlikely to present like our patients with these germline alterations, which can be younger and have many tumors on both kidneys. And it's a different approach to managing both patients.
Got it. So, I think a common question that I seem to get, and I'm sure you do as well, when you see these patients with somatic or sporadic mutations, right? And there's have clear cell carcinoma, for example, right? And they say, doctor, like, what caused this? Why did I get this mutation? How do you typically counsel those patients? What do you tell them for those?
I think it's really important to give it in a way that's understandable. We can use terms like stochastic and things like that, but I think you lose that in translation.
100%. Yeah.
A lot of times when I talk to patients, regardless of the histology, regardless of the tumor type, kidney, prostate, bladder, when we're talking about sporadic tumors, I generally tell people it's a lot like the game telephone. So when cells are duplicating and replicating in the body, they send these messages, your genes, and they play a game of telephone where they whisper a certain message to the next one down the line. And if you recall, when you as a child, when you play these games, you're whispering it down the line, down the line, down the line, and then 10 to 12 people later, the message is completely garbled or completely different, or one word has changed. It really changes the message. And I tell them there are different alterations to the game. There are people that come in and fix the message, et cetera. But at some point, it alters and changes, and you have a different message, and that's one of those triggers for cancer. So it is, for a lot of people, random. There are things that can make it better or worse, or more likely or less likely to happen. But for the most part, for sporadic tumors, that stochastic or random event chances are the ones that usually lead to this. But I think that really that game of telephone, it really kind of hits well with a lot of people.
Yeah, no, that actually makes sense. Yeah. So let's shift gears and kind of go back to hereditary kidney cancer, right? So, you also kind of said HLRCC, SDHB, VHL, right? But, just kind of giving a little bit more background, of those hereditary kidney cancer syndromes, what is the most common And, for someone who's in clinical practice, whether it's, 5 years, 10 years, 2 years, what is really the most important clinical manifestations of probably the most common one?
Yeah, so there are a number of hereditary or different hereditary kidney cancer syndromes. We mentioned there's 19 genes that are tied to this, but for clinical practice, I think it's important to focus on a few select, more commonly noted entities. So you mentioned VHL. I think
Yeah.
VHL is one of those ones that can come across a urologist or oncologist, especially now more so than before. And,
Yeah.
and this VHL, it's short for von Hippel-Lindau or von Hippel-Lindau disease. It's an autosomal dominant syndrome. It's characterized by a number of different findings. Patients can present with malignant tumors such as clear cell RCC and pancreatic neuroendocrine tumors. Other notable things that they can have are pheochromocytomas, CNS hemangioblastomas, retinal angiomas, and other rare things such as endolymphatic sac tumors and epididymal cyst adenomas. So when people are picked up with this, these it's usually when they present when these entities develop some sort of clinical manifestation. It's just hearing, vision alterations, neurological deficits, and honestly, incidental imaging findings in the adrenal or kidney or pancreas.
Yeah.
And I gave you that laundry list of things to look out for.
Yeah.
It's important to realize that it really does require a multidisciplinary team: urologists, neurosurgeons, surgical oncologists, ophthalmologists, in following these patients. And it's, this is one where you should really rely on your other teammates and other practitioners to help you with managing these patients.